Thank you all so much for coming. It's so exciting to see a packed room and see a lot of familiar faces, and I hope I get a chance to meet some others at the end of this presentation. I also want to acknowledge my co-authors. Several are in the audience. You are free to just whisper your questions to them as we go through this. I don't need to answer anything else. They know everything. This research was funded by the National Institute on Aging. The content is solely the responsibility of myself and my co-authors, so it does not necessarily represent the official views of NIH. I also have no conflicts of interest to disclose, and I'm presenting here the conflicts of interest for Stacy Lindau, who's the PI on this study. So 1 in 5 US adults is a caregiver for an adult family member or friend. That's more than 50 million US caregivers. About 30% of these caregivers care for somebody that has Alzheimer's or dementia. The number of people that are caring for folks with dementia is growing as the number of people with dementia is growing and our population ages. Caregivers need resources to do their job. To be a caregiver, there's lots of things you need for yourself and to take care of that person that you're trying to care for. In a 2013 study, 89% of caregivers said they had at least one resource referral need, but concerningly, a subsequent study found that only about 19% of caregivers, specifically dementia caregivers, felt like they knew how to access the community resources they need. So they're acknowledging needs, but they don't really know what to do to go find those resources. Caregivers interface with our healthcare system for their own care, but they also often accompany the person that they're caring for. That routine care, really in line with the National Academies of Science and Engineering and Medicine's proposed approach for strengthening social care and medical care integration, is an opportunity for us to intervene and help those caregivers find those resources that they need. Our solution to this need for interventions that assist caregivers with their needs during medical care is called Community RX. I'm sure some of you attended the presentation earlier for pediatric social care interventions. This should look familiar. This is a concurrent trial that was running at the same time. Community RX is a low-intensity, high-scale, evidence-based intervention that our team has developed over the last 15 years in partnership with the Chicago Southside community. Community RX has been, and it continues to be, iterated for different populations to meet the needs of those populations. So we have several trials running in hospitalized, caregivers of hospitalized children, people that have chronic kidney disease, bereaved parents, adults with diabetes, hopefully lots more to come. This figure illustrates the essential components of Community RX dementia. So that's an iteration of that social care intervention specifically for caregivers of people with dementia. Within 7 days of an outpatient visit for either the caregiver or the person that they're caring for, a navigator contacts the caregiver and initiates the intervention. The first component on the far left is some education, a little scripting around what are common needs for caregivers. The next piece is activation, so the navigator walks the person through a healthy RX. You see that in the center. That's a personalized list of resources. Those resources are close to the caregiver's home or some other address, like maybe where they work. And then the last piece is this ongoing proactive boosting where we send automated text messages that look like they're coming from the navigator, but they're from a text messaging system, so a little bit less work for the navigator. They say things like, hey, can I help you find anything else? Have you heard about the new garden that's down the street? And then they give the caregiver an opportunity to reply and say, yeah, I really need help with something else. This is a slightly easier to see version of that Healthy RX on the left. We provided referrals for more than 10 resource types. The resources that were included on the Healthy RX were informed by published dementia care guidelines, prior research, and interviews with caregivers that live in our community. The caregivers got information about all of those resources, even if they didn't express a need for those resources. We call this universal delivery, like putting fluoride in the water. We know that needs change over time. So maybe you don't need a support group today, but next month you do. You got your piece of paper, you can go back to it and find it. For this study, we hypothesized that the dementia caregivers who received CommuniRx dementia would have fewer emergency department visits and hospitalizations over 12 months compared to those who did not receive the intervention. At our healthcare system, nothing like yours, Mary Catherine, nothing so really amazing and systematic and organized. Ad hoc social care is what usual care is, and that's a nurse who sees somebody that needs food and directs them to a pantry or something like that. It's not systematic, really. The RCT was conducted at an urban academic medical center. The participants were English or Spanish speaking, which is the majority of our patient population, and they were caregivers of people that were living at home with dementia, so they weren't in long-term care. The caregivers lived in one of 42 zip codes that surround our medical center and were willing to receive text messages. Very few people couldn't or weren't able to receive text messages. I think ultimately maybe one person out of thousands screened was ineligible for that reason. Participants were enrolled December 2020 through February 2023, again following that outpatient visit for themselves or the person that had dementia. This illustrates the delivery of the intervention and the data collection. So delivery of the intervention is on the top, data collection is on the bottom. We used critical time intervention theory, so really sent more messages up front right after the appointment, we're here for you, and then they sort of slowed down over a 3-month period. Follow-up surveys were conducted at 1 week, 1, 3, 6, and 12 months. Those were done by telephone or an online survey, depending on what the caregiver preferred. The pre-specified outcomes I'm reporting on today were self-reported number of caregiver emergency department visits and hospitalizations at 12 months following baseline. These were secondary outcomes in our study. We used a measure that was developed for a randomized control trial among diabetes patients. A number of studies have assessed the accuracy of self-reported acute care. One of the most relevant of these is by Short et al. And compared self-reported healthcare utilization with that 12-month recall against claims data for about 7,000 people, and found that the accuracy of recall was greater than 90% for both ED visits and hospitalizations. Lost track of my buttons for a second, found them again. Negative binomial regression models were fit with treatment groups, so intervention to control, and then baseline utilization as predictors. We calculated the incidence rate ratios and corresponding 95% confidence intervals for ease of interpretation. The mean caregiver age was about 60 years old. Most of our caregivers were female. Most caregivers identified as African American or Black, and most were caregiving for a parent or a parent-in-law. About 2/3 of caregivers had at least one of the health-related social risks that are shown here. We assessed that using the AHC screening tool that many folks are using. I think it's important to note that we assessed it as part of the research data collection. It was done before the intervention. It was not done as part of the intervention because this was universal delivery. The most common needs or risks, I can't misspeak on that point in this crowd. The most common being social support, financial strain, and housing instability. In the 12 months following baseline, 22% of intervention group caregivers had at least one ED visit, and 28% of controls had at least one ED visit. And then about 12% of intervention group caregivers had one or more hospitalizations during that same time frame compared to 16% of controls. The results from the modeling are shown here. Recall these are only adjusted for the baseline healthcare utilization. On the left, you see the incident rate ratio was 0.56 for ED visits. The 95% confidence interval did not cross 1, which suggests a significant reduction in ED utilization. For hospitalizations, the incident rate ratio was 0.65, but the 95% confidence interval did cross 1. So we find high rates of social risks among caregivers of people with dementia. That's not new news. That corroborates prior findings. We also find pretty frequent use of acute care over 12 months. CommuniRx reduced the number of ED visits at that 12-month mark, which also corroborates findings from rigorous studies in different populations. These findings should be interpreted in light of a few limitations. So we did use that self-report healthcare utilization. I've told you I think that's pretty accurate, but there could still be some limitations. This was done in a single region, and we also did it during the pandemic. We know HRSRs changed. We know access to resource changed. We know utilization changed. So it's really difficult to know how those changes would have impacted how the intervention itself functioned during that time period. So to conclude, we wonder if the integration of a low-intensity social care intervention like this during medical care could be sustained through cost avoidance from reducing acute care. We're also really thinking carefully about the mechanisms by which this works, and I've heard that come up a number of times already today and yesterday. I'm going to give a spoiler that wasn't in this presentation, but our primary outcome was self-care, self-efficacy for caregiving, and we really thought that was the mechanism. We thought it was people are going to get more confident, they're going to use resources, and then their care is going to be reduced, the acute care, because they're going to be healthier. We don't see that. We saw a lot of people coming in with really high self-efficacy. They thought they felt confident they could find the things that they needed. We didn't see huge jumps in use. We don't see significant differences. So those aren't it. But we're starting to think about this path of improved emotional support, especially with the navigator there. Is it connecting to the bridges of the world? Is that what's really driving this change? And I know I'm supposed to be here like giving you information, but I'm asking instead for help figuring that out. What are we going to do to really understand how that emotional support might be the mechanism by which this works? Because I really believe if we can figure that out, we can only make these interventions better and better. So please, any ideas, I'm taking them. That's all I have. Thanks so much.